Well, first of all, I would like to thank you for the invitation. It's certainly a great pleasure for me, an honor, to come over to St. Petersburg. I've never been here before, and I spent 4 hours this morning in walking around this beautiful city. I was given the task to briefly review the stratification to optimize management of men with BPH. And to review this issue, I have grouped the talk in 3 chapters. The first one will highlight risk factors for progression of BPH and to demonstrate the multifactorial process of this disease. In the second part of the talk, I will briefly review why it is important to treat progressive disease early, why it is wrong to treat a patient who is at risk of having progression, for instance, just with an alpha blocker as a monotherapy. And the third part will briefly cover the issue on which cutoffs should be used in order to initiate combination treatment, for instance. Let's start off with the first part of the talk. What is disease progression actually? And disease progression in BPH can be either symptomatic progression or the risk for acute or the incidence of acute urinary retention or BPH-related surgery, or all 3 together. How frequent is BPH progression in elderly men? To assess this issue, you would need long-term follow-up studies over several years, and only a few long-term studies are available. And this one is probably the most famous one, the MTOP study, that has analyzed a group of men over 4 years. And the slide over here just analyzes what happens if men with BPH LUTS are treated with placebo over 4 years. And it's worth to note that within 4 years, not everybody is experiencing progression. Only about 20 to 25% of men experience disease progression. And of those that experience disease progression, deterioration of symptoms is the most important one. It occurs in about 80%. When you have a look at this data and you say, well, 20% is not a whole lot over 4 years, you have to understand that mean prostate volume in the MTOP study was only about 34 mLs. So these were men at low risk, at a rather low risk of disease progression. If we would have here a group of men with larger sized prostates, and you will see then a slide at the end of my talk, you will notice that the risk of retention or progression is much, much, much higher. But even in a higher, even if the prostate volume is higher, the distribution of progression remains the same. It's about 70 to 80%. It's symptomatic progression, and the rest is acute urinary retention and surgery. So it occurs rather frequently, progression, but it does not occur in everybody. Why is this the case? Well, first of all, we have to understand that the pathophysiology of lower urinary tract symptoms is multifactorial. It is much, much more than just the enlarged prostate. There are many, many more factors involved, such as probably inflammation, changes in the vascular system, autonomic nerve system overactivity, detrusor fibrosis, and many, many, many things more. So it is a multifactorial process explaining in part why it is not progressive in everybody, because men have different pathophysiologies. And from the etiological standpoint, it's also different. It's also multifactorial, because men that present with LUTS, From the urodynamic standpoint, they can have the true overactivity, they can have benign prostatic obstruction, they can have the true underactivity, which is now more frequently recognized, they can have nocturnal polyuria, and many, many, many other things. So it is a multifactorial process. And LUTS is not LUTS in men. It's a huge study with about 20,000 men, and it demonstrates that some men present with voiding symptoms only, some men present with storage symptoms only, and others have a combination of various symptoms. And it makes sense that these men over here, who have voiding symptoms only, have a different pathophysiology than those down here who have storage symptoms only. That these men have a different risk of progression like there are others down here, and that these men require a different treatment than the man down here. So it is multifactorial. And I have emphasized this already, it is not necessarily a progressive disease. And we know this from many years. This is a study we have done a couple of years ago in Vienna, where we have followed 500 men with LUTS over 5 years. And at 5 years, we analyzed whether their symptoms have got worse or have become better. And you see that over 5 years, there is, of course, a tendency that symptoms get worse. But even over 5 years, in a certain percentage of men, symptoms become better, even over a long period of time. And you always have to keep this in mind when you counsel patients and when you manage patients medically or surgically. So which parameters can change over time? And it's well known from many studies that actually all parameters involved in the LUTS field change over time. Its symptoms change, bother changes, prostate volume changes, Qmax changes, the risk of urinary tract infection increases, risk of retention increases, and things like that. So all these parameters that are involved in this field tend to increase with time. And it is in fact, it is a progressive disorder. And we know from many studies that about 1/3 of men eventually require, I don't know how the data are here in Russia, about 1/3 of men ultimately require BPH surgery. In my country, we have done an analysis of men older than 80 in several hundred, and in this group of geriatric patients, about 1/3 previously had TUR surgery. So the risk of a 60-year-old man to require surgery within the next 20 years is 20 to 30%. And 60% of all patients, and this has been elaborated frequently, they fear. They don't, although we as surgeons, we like TUR, patients usually don't. So they fear retention and surgery. So what determines if somebody is developing a progressive disease and not? What are the factors for disease progression? And actually all parameters involved in this field, as I've shown you before with this circle, actually all these parameters can act as risk factors for disease progression. And the first one, of course, you can nothing do about that, that's age. And many studies again have shown that the older you get, the higher are your symptoms. This is well understandable for everybody to us. And age is also a risk factor for the risk of acute urinary retention. The risk of a 50-year-old man in developing retention in the next couple of years is 3 to 5-fold less than somebody in his 70s or 80s. So age per se is a risk factor. And of course, the most intensely studied progression parameter is prostate volume. This has to do, of course, with the industry behind this development and the drugs that we have available. But prostate volume is the most intensely studied progression parameters. And this is PLES study. This is a 4-year study. It was done finasteride against placebo. This is the placebo arm. And you can see that the risk of retention within 4 years increases from about 10% in men with smaller sized prostates to about 25 to 30% in those with larger sized prostates. So it's a huge difference. It's a 3 times difference, suggesting that prostate volume indeed is a prominent and important risk factor for the development of retention and for requiring surgery. Flow rate, again, although the importance, I don't know how the situation is in Russia, but there is now the tendency that flow rates tend to become as a less important parameter, but it is a progression parameter, and again, the risk of retention over several years, this is Olmsted County, showing that patients that have a decreased flow rate have a 3 to 4-fold higher risk of developing retention. So flow rate per se is a risk factor as well. And PSA. You can argue, maybe we can have this in a discussion. This comes from a United States study. I personally don't believe that PSA is a good factor for disease progression, but when you analyze clear studies, you can show that PSA as a proxy parameter for prostate volume is also a factor for disease progression. Why? Men with larger sized prostates, they have higher PSA because there's a close correlation between PSA and prostate volume. It's not that PSA per se is a factor, it is because PSA is a proxy parameter for prostate volume. And it's actually very frequent in your BPH LUTS cohort that you see on an everyday basis that you have a group of men that are at risk of disease progression. This is a European study and a Canadian study, both showing about the same, that at least 50% of the patients that you see in your daily practice for male LUTS, at least 50% are at risk of disease progression. Because we know that about 50% have moderate to severe LUTS and about 50% have prostates larger than 30 to 40 ml. So it is a significant proportion of men that are at risk of disease progression. We have to remember these figures when we then analyze some prescription data. So this was the first part. Why is it important, or why is disease progression bad for the patient? This slide is a sort of a theoretical slide, and it's based on many experimental studies in animals. And it suggests that when there is bladder outlet obstruction, this will ultimately lead to irreversible structural changes in the bladder, which will lead to irreversible urodynamic changes, which leads then to bladders with poor compliance, poor contractile function, and which leads then to long-term complications. Well, this is experimental data. And I will show you in a minute 2 studies which suggest, or which prove actually, that this is the case. And we know for many years, and we have analyzed this also in several studies, that there are well-known age-related changes within the lower urinary tract, which are at least in part due to the progressive nature of the disease. We know that the detrusor contractility goes down. We know that bladder capacity goes down. We know that the Qmax goes down. We know that bladder outlet obstruction increases. We know that the detrusor overactivity increases, post-void residual as well, and nocturia. So there are many urodynamic changes which are taking place in the elderly lower urinary tract, again, which are, at least in part, due to the progression of the disease. I will skip this slide, and I will show you 2 studies which demonstrate that it is important to treat progressive disease early. This study is a very famous one. This is the 5 years outcome data of the only study ever done that compares TURP to watchful waiting. The very famous Flanagan study. Wasson study, originally published in the New England Journal of Medicine. And I would like to draw your attention just to this column here. This is the group of men that I have circled in that had, just as an example, a low Qmax at study entry. And these men were either randomized to immediate TUR, this is the yellow bar, or to delayed TUR, which is the orange, I think it is the orange one. So the yellow group was the men that were randomized to TUR, and the orange bar is the group that were initially randomized to watchful waiting and then received TUR in the course of the study because they did not respond adequately. And when you look at the outcome at 5 years, there is a difference. Patients that were immediately randomized to TUR had a better 5-year outcome. Why is this the case? Because over these years, the natural history of the disease, the progressive nature of disease, obviously caused or led to irreversible urodynamic and functional changes. That is why if somebody deserves treatment for progressive disease, it needs to be treated properly and fast. And this study shows the same. This is a tutasteride study, and this is the open label study. And when you have such an open label study, you can compare a group of men, which is the lower curve, that these group of men, about 1,500, they had 4 years of tutasteride. The group up here, the other graph, they had 2 years of placebo, and after 2 years of placebo, they switched to tutasteride because of the open label study. And what is shown in this graph is the risk of retention. And what you is shown over here is that when you give tutasteride after 2 years, the curve for retention skips, and it runs in parallel to men who were who had early treatment for tutasteride. But even after 4 years, there is a 50% difference, suggesting early treatment, these men had 4 years of tutasteride, is better than 2 years of watchful waiting or placebo, and then giving tutasteride. So early treatment leads to a better outcome than delayed treatment. Again, why? Because in these men, the natural history of the disease changed the urinary tract untreated over 2 years. So early treatment leads to a better long-term outcome. And I will skip this as well. The consequences of retention, it's feared by the patient, it's why it should be avoided by appropriate treatment is, you know all this, it's an emergency, it requires catheterization, there's anxiety, stress, there are complications of catheterization, there's surgery, complications of surgery and costs. So from the healthcare perspective, retention should be avoided, of course. The last part will briefly discuss on clinical relevant cutoffs. Maybe you've seen this slide before. This is the AAU guidelines, and I cannot go into detail, but they make one important statement, that is, they stratify treatment based on prostate volume. And this stratification and this recommendation is the concept in urology which is the most solid one, because several thousand men have been analyzed in proper designed study, placebo-controlled, over up to 4 years. So this recommendation is very, very solid, that patients who are at risk of disease progression should receive 5-alpha reductase inhibition. And you can argue which cutoff you would use in your practice to give 5-alpha reductase inhibition. It is very clear that the beneficial effect of 5-alpha reductase inhibition is dependent on prostate volume. The higher the prostate volume is, this is combat data, the more prominent is the effect. Let's look at the extreme on the right side. These are men with prostates larger than 60 ml. If you give such a man an alpha blocker as a monotherapy, his risk of going into retention is almost 20%, just within 4 years, which is a very short period of time. And if you give him guideline recommended therapy, if you would give him a combination therapy, his risk is about 4 to 5%. It's about a 70% relative risk reduction and a huge absolute risk reduction. So if you give him the wrong therapy, his risk of retention is very, very high. But even this difference is also demonstrable in smaller sized prostate. The message here is, based on this data, you should make your own cutoff when you believe these data are relevant. But it is wrong to do not respect the effect of prostate volume. The problem is that urologists all over the world do not follow these recommendations. These are European data, and again demonstrating that still, even today, and I heard yesterday that it is the same as in Russia, it's the same in Russia here, that alpha blocker monotherapy is the dominant form of treatment, and 80 to 90% of all men receive alpha blocker as a monotherapy as the initial treatment. And based on the guidelines and based on the distribution of men at risk that we know that about 40 to 50% have larger size prostate volumes, these figures should be higher. Not 100%, this is also wrong, but probably 30 to 40 to 50%, but sure not 10%. This is not respecting the guidelines. This is Europe, and it is the same in Canada. This is a study published by Curtis Nichols a couple of years ago, suggesting that only about half of the men receive guideline-recommended therapy, and the other half is treated not following these guidelines, which are based on very, very, very solid data. And this is my take-home message, and I'm already finished, that LUTS BPH is a progressive disorder. This we know from numerous long-term, large-scale trials. It's not progressive in everybody, but it tends to be progressive. There are multiple risk factors involved. It's not just like the prostate. There are many, many, many more factors. Prostate volume is not the only risk factor for disease progression, but it's the best studied risk factor for disease progression. Guidelines suggest a stratification of patients. They suggest an individualized management based on symptom status and based on the risk of disease progression. And unfortunately, this is true in Europe and true in Canada and probably also true here in Russia. There is a poor guideline compliance regarding the risk stratification of these men, particularly regarding the risk of disease progression and the risk of retention, irrespective of the role of prostate volume in the disease management. Thank you very much.